Hello, everyone. Thank you so much for attending our webinar. I just want to quickly, before we begin, make sure that you can all hear me. So if you can just type yes into the chat box, that would be great. Amazing. Perfect. I'm seeing lots of yeses. Thanks so much. So welcome to Asthma Canada's Asthma Basics webinar series, an introduction to asthma. Our webinar series has been made possible through educational grants from AstraZeneca, Novartis, GSK, and Sanofi Genzyme. Today, we are getting back to basics with an introduction to asthma that's for both people who are newly diagnosed and for those who have been living with asthma for a while. For many members of our community, I know the pandemic has highlighted just how important maintaining asthma control is, not to mention the importance of your overall health. And I know many of you have been looking forward to this presentation, so thank you so much for joining us. My name is Kristen Vawa, and I'm the Manager of Communications, Programs, and Public Engagement at Asthma Canada, and I'll be your host today. So before we begin, I'll just go over a couple of quick points. This webinar is being recorded and will be uploaded to our website shortly, so please do feel free to share within your networks once the recording is public. All attendees are muted, but at any point, if you have any questions or comments, please type into the chat box. I'll be monitoring that throughout. And of course, there will be a Q&A at the end. Thank you so much for those who submitted questions in advance. You can also type your questions in the chat box as we move through the presentation. So very quickly, I'd just like to highlight some of our work. Asthma Canada is the only national organization solely dedicated to helping all Canadians affected by asthma. At the heart of all we do is our vision to empower every child and adult with asthma in Canada to live an active and symptom-free life. We are committed to improving the lives of the Canadian asthma community through education and support services, advocacy, and research. Asthma Canada encourages self-management by helping our community take control of their symptoms. We do this through our educational resources and services like our Asthma and Allergy Helpline and our webinar series just like this one. We're also committed to bringing your voice to the forefront of policy decisions that affect our community, advocating on important issues like sustainable clean air and energy, choice and access to treatments, and access to medication in schools. Our annual asthma survey is also now open. We encourage you to take part. You can participate by visiting asthma.ca. And of course, Asthma Canada supports research into better health outcomes and the eventual cure for asthma. Our national research program supports graduate level students studying early or late onset asthma. Much of the work we do is through our community of volunteers and members across the country. People living with asthma, their families, parents, caregivers, healthcare professionals, educators, and others who are strongly committed to improving asthma care and quality of life. The Asthma Canada Member Alliance is a free membership of Canadians who engage in all the work we do and provide support and input into our initiatives. So I would absolutely welcome you to join us if you haven't already. And now I'd like to introduce our distinguished presenter, Dr. Alan Kaplan. Thank you for having your camera on. Dr. Kaplan is a family physician practicing in York Region, Ontario. He is the chairperson of the Family Physician Airways Group of Canada and the past chairperson of the Respiratory section of the College of Family Physicians of Canada. He is a Senate member of the International Primary Care Respiratory Group and was the representative of the College of Family Physicians of Canada to the SARS Clinical Working Group. A member of the Health Canada section on allergy and respiratory therapies, he also co-chairs the Health Quality Ontario COPD Community Management Standards Committee and is a board member of Thrombosis Canada. Dr. Kaplan is also the vice president of the Respiratory Effectiveness Group. Thank you, Dr. Kaplan. It is a pleasure to have you back with us. And now I'm happy to pass the presentation along to you. Oh, sorry, one moment, Dr. Kaplan. I don't think we can hear you.
right. Can you hear me now?
I can. There is a bit of feedback, but we can hear you.
All right, you can hear me on the computer line. That's all right.
Yes, perfect.
Okay. All right. So I've called in, but I'll hang up my call in so you just hear me through the computer. That should be fine. So again, welcome everybody. Sorry for the technical issue. My apologies for being a moment late, Kristen. I was so busy working on a vaccine hesitancy talk, I lost track of the time. This is a complicated time for all of us right now with COVID. So we're trying to have this conversation as well. But I'm going to talk a little bit about asthma today, and I want to just reemphasize the Asthma Society and the good work that it does. And for those of you that are asthmatics, if you haven't done the survey, please do so, because we use that information to help guide us in terms of educational programs and advocacy across the country. So what Kristen's asked me to talk about today is really going about asthma basics. And I thought we'd sort of talk about what you should know and how you should review this with your doctor to ensure that your care gets optimized during your visits. So we're going to talk a little bit about that. So she's already given you all this stuff about me. In addition, I work with just about every company that makes anything inhaled as well. So I'd like to say that I'm so biased, I'm not biased anymore, because I work with everybody. So what I'd like to talk about is talk about for you a little tiny bit about inhaler technique. A little hard to do this in a webinar, but please, if you don't know how to use your inhaler, please make sure to learn how to use it properly. Otherwise, the medication doesn't get to your lungs. We'll touch on that. We'll talk about the different medications, the relievers versus the controllers, and what you should know about those. We're going to talk about when you should visit your doctor and how you should communicate with your doctor. Talking about things like your asthma control, talking about things like which medications you're taking and how, having an action plan, and where to go to get more information about that. So we're going to go through some of those issues here today. So our goals of asthma management are to improve the quality of life of asthma, such so that hopefully you have no symptoms at all. Unfortunately, at this point, we don't have a cure for asthma. But by good medications, using your controllers, relieving your triggers, dealing with the comorbidities, we'll talk about all that, you should be able to actually live asthma symptom-free. And that's what you should strive for. You shouldn't be satisfied for being limited by symptoms, missing life opportunities, not going to work or school. You should be aiming for complete control. We'll talk about that. So living symptom-free, so that means no cough, no wheeze, no waking up at night, no grabbing your puffer during the day. You're not having to use a puffer to exercise. Living your life as if you didn't have asthma, but that's going to require some treatment on your half to get that. So how do we do that? Well, how do we get you to the point where you can sleep through the night without having any asthma symptoms at all? That's the first question I think is really important. If you're waking up at night because of your asthma is not in control. You need more treatment. You need adjustment of your treatment. It's not okay. Don't accept it. It's something to discuss with your family doctor about it, or your specialist about, that your asthma is not controlled. We want to prevent asthma exacerbations, attacks, and hospitalizations. Never should you have to rush to the hospital because you can't breathe. You should be able to fully participate in your life activities, in your sports, and so on. While this sounds like this is a pie in the sky kind of things to say, for virtually all asthmatics, we should be able to reach that kind of level of control. Some of you may have severe asthma, in which case it may be a little bit more difficult, but even with our new medications like biologics, you should be able to reach to those kind of outcomes. Asthma with exercise is an interesting thing, and I would consider that two different diseases. The first is someone whose asthma is not controlled. If your asthma is not controlled, then any trigger at all will cause symptoms. Triggers can be allergens and exposures, it can be a viral infection, and it can be exercise. There's another group of people, though, that have exercise-induced bronchospasm. And the difference there is this is not eosinophilic inflammation mediated. It's related to dryness and temperature change. And for that, it's a little different of a situation. You don't have symptoms other times of the year. You don't have symptoms with colds and pollens and trees and things like that. You just have it related to exercise. That's not quite the regular exercise-induced asthma. That's exercise-induced bronchospasm. And the treatments for that, they're a little different than treatments for asthma. And that can include a saddle beforehand and some other preventative treatments. But most importantly, things like just warming up properly and going gradually from temperature extremes can make a difference to that. The rest of us who have exercise symptoms, it's because our asthma is not well enough controlled. So I'll go back to that mantra. We need to get our asthma perfectly controlled. How do we do that? We have to take our medications regularly. We'll touch on that. But it also means you may have to adjust your medications depending on the situation. Asthma is a variable condition. It gets better, it gets worse depending on what's happening, the amount of pollen in the air, the temperature, the humidity, your mood, many things will affect your asthma control. So we have to understand what we do and when, and how to step up therapy a little bit when things are a little bit worse, and how you can step down therapy when you've had a good period of control. But the key messages here is please take your medication that you're prescribed regularly, do it as you're instructed, and take it properly, which we'll talk about, and use only your reliever when you have to, and hopefully by minimizing your reliever use, your quality of life is better. So when someone's asthma is not in control, and what does asthma lack of control means? Well, it means that your life is being affected by your asthma. You've missed work or school. Your lung function is not as good as it can be. That you're using your short-acting reliever more than a couple times a week. And I would say even that's perhaps more than we should be aiming for. That you're waking up at night, the things we just talked about. So what if that's happening, that you're not in control? How do we assess that and decide where our steps are from there? Well, the first question is your diagnosis correct? That seems a little bit silly, but I'm hoping most, if not all of you, have actually had a test done to confirm your asthma. That test could be spirometry, where you blow into a machine and it measures whether you have obstruction, or it can be further advanced where you do a challenge test where we give you medications to see how much it takes to make you wheeze. And of course, if you need just a little tiny bit of that medication, your diagnosis, first of all, are you using it regularly the way you're instructed? Are you using it correctly? We'll talk about devices. Is there some exposure that you could avoid? And that exposure could include things like cigarette smoke, which I'm hoping none of you do smoke. If you do, we can talk about how to decrease that and relieve it. That includes smoking other things such as cannabis. It even includes vaping and e-cigarettes. If you're using that for smoking cessation, of course, that's still better than smoking cigarettes. Is there some other trigger? Do you have a pet at home? And I understand our pets are important members of our family, but we have to minimize their exposure if you are pet allergic. Do you have a mold in your home? Do you have dust in your mold? Do you have dust mites in your bedding and your cushions and so on? All these things are things you can do something about to minimize your exposure. And of course, is there other comorbidities that can be worse than your asthma? Do you have heartburn or acid, and the acid can come up and burn your lungs? If you have nasal congestion, the inflammation in your nose is related to the inflammation in your lungs, that could be an issue. If you have sleep apnea, which can affect your asthma control. So you see there's many things there that can make a difference. We have to optimize all those things to make you better. Well, here's an extreme example of a bronchoscopy. And you can see on the left is a normal airway. This is someone putting a telescope into the lungs and looking down into the bronchi. And you can see that the normal airway on the left, it's not swollen, it's not red. Versus on the right side, it's swollen and red. And more importantly, you can see that the lumen is narrowed. That lumen is narrowed because of swelling in the airways and because of some bronchospasm. So that's what we don't want to see when we look into an airway of an asthmatic. But looking at this more in terms of a pictorial thing, and the concepts here are a normal airway. There is some muscle in the airway. There is some mucus glands in the airway. But when you have the inflammation of asthma, the inflammation in that submucosal layer with eosinophils gets very significant. Then inflammation causes the airways to actually swell. Then the muscles go into spasm, and then the muscles hypertrophy or get bigger. As they get bigger and thicker, it's harder for them to relax. Those mucus cells also proliferate, and we make more mucus. So you make more mucus, it's plugging out the airways because of mucus and spasm and swelling, and that's what happens in your asthmatic airway. So looking at this again, you can see again in the center of this is a mucus plug. You're seeing these cells in the submucosa that are called eosinophils. We see the basement membrane over time gets scarred and gets thickened. The smooth muscle thickens, the mucus cell hyperplasia. So again, that's the anatomy of an asthmatic airway. So our job here is not just to give a bronchodilator to open up the spasm. It's to control the swelling. It's to reduce the mucus. It's to clear up those mucus plugs and to do all those things to help our asthmatic airway. So bronchoconstriction is what we think about. When people talk about asthma, they talk about the airways going into spasm. But I want to reiterate that the spasm is a secondary event for most people because of the inflammation. And therefore, if we treat the inflammation, we can prevent the spasm. Going back to exercise, for instance, that spasm that occurs in exercise-induced asthma is because of the inflammation that leads to the trigger of exercise causing the spasm. So they treat the spasm, but we want to prevent the spasm by treating the inflammation. This is our Canadian guideline picture from 2021, and it includes overall where we're trying to approach. So I want to start off with this box in the left, which talks about how do we assess someone with asthma. And again, first of all, are you controlled? The questions we asked. Have you had exacerbations or not? It changes our plan. Have you had a diagnostic test like spirometry? Have you reviewed your inhaler technique? Are you taking your medication regularly the way you're supposed to? And listen, I understand it's hard to take medication regularly. I get it. But the corollary here is if you take your medication the way you're instructed regularly, we can prevent you from having asthma attacks and symptoms. We always aim for the low dose to keep you controlled, and that's something you work on with your physician. But again, are you taking your medication regularly? Have the triggers been dealt with? Have you dealt with the comorbidities? All those things are there. So where we want to start with, you can see this arrow is starting with inhaled steroids. And there's no place there for starting with SABA anymore. SABAs are short-acting beta agonists like Ventolin or Bricanil are very good drugs for what they do, but they don't treat the condition. They treat the symptom. What we really want to do is you see a step up with inhaled corticosteroids, which treat the inflammation, adding on other therapy as you need, such as a long-acting beta agonist, a leukotriene receptor antagonist, a long-acting muscarinic antagonist. There's a variety of things we add on as therapies, moving all the way up to biologics if we need to. But the important message here is increase your inhaled steroids until you get control. Now, our reliever has changed a little bit over time. We used to talk about SABA as the reliever, but the option is to use budesonide formoterol. In Canada, that's called Symbicort, to use that as a reliever because the reliever has something to open up your lungs but treat the swelling at the same time. So you're treating the inflammation at the time it happens. But as you can see overall, make sure you're treating the environment, deal with the things that are the triggers, understand how to use an action plan, which we'll come back to after we confirm the diagnosis. So that's the overview. But I want to talk again about how important it is we use inhaled steroids at the beginning of this picture. So we talked about this. If you don't have good control, an article we wrote in 2008, it's still true today. Make the diagnosis. Make sure you're taking your medication. Make sure you're taking it properly. Deal with those comorbidities we talked about. Deal with the triggers. Now let's talk a little bit about triggers. I mean, we understand that triggers of pets, how you deal with those little triggers each time and how to take care of those triggers. So, we have things like this that I've shown in the pictures here, and this will ring true for many of you. Let's talk about them. Cats and dogs, I've got both, and I know how difficult it is when you've got pets if you're allergic to them. But there's a few things you can do to minimize your exposure. First of all, of course, you can keep them out of the bedroom, which is hard. If anybody has a cat, you know how hard it is to keep them out of the bedroom. You can try to keep them off your bed. You can make sure that they are washed regularly because you're allergic to their dander. And if the dander is being washed off, there's less of it to spread to your house. You can make sure that the pet has a place to be washed outside of the house or away from you and someone else is doing it. We talk about washing cats being particularly effective because they really hate it. They'll make them run away, but my tongue is in my cheek. Obviously, exposure to pollens and molds and grasses if you're allergic is important. Something as simple as closing your window in the springtime when the grasses and trees are flowering and using air conditioning to filter may make a difference. By the way, using an air filter is something a lot of you reach for to get help. It's probably mostly of value to have a HEPA filter on your furnace for pet allergy because it's big enough to get caught in the filter. We talked about smoking, we've talked about vaping, we've talked about cannabis. There's a little bit about food allergy there. If you happen to be food allergic, that makes it a little bit more complicated, but it's something to work on as well. And I'll come back again to dust mites, these little critters in the bottom corner. These are little insects that live in your bedding, live in your pillow. Now, a mattress and a feather pillow after about 5 years has 50% content of dust mites. It sounds horrible. But in fact, we're not allergic to the dust mites. You're allergic to what they poop, and they otherwise do you no harm at all. They don't hurt. They eat your dead cells that you flake off in your bed. They're completely benign. But if you happen to be allergic to their poop and you spend 8 hours in bed inhaling that allergen, it's going to cause issues. So you can take care of something simple like that by putting covers on your beds and your pillows, washing your stuffed animals, and so on, washing your bedding with very hot water to try to make sure that you're killing the dust mites. In terms of the comorbidities, I've touched on this already. Acid reflux is a big one. Obesity has its own actually phenotypic difference when it's asthma. So if you are overweight, losing weight makes a difference. Now, weight will also increase your GERD, which is part of it, but actually there's actually an inflammatory milieu that's different in your body that actually worsens your asthma. And I'm just working right now on some work about obesity and asthma, where we actually learned that bariatric surgery, where you do stomach stapling, things that actually improves asthma in people who are very heavy. And some of the asthma medications, we're just working with this database trial right now that looks at some of the asthma medications, particularly GLP-1 antagonists, will actually decrease asthma outcomes as well. Now, sleep apnea is an issue as well. Obviously, the airway can get irritated with that if you don't treat it. And I really want to touch a little bit about mood. So mood and anxiety is going to both be a cause of asthma things and a result of asthma. So try to make sure that we actually deal with those issues as well, that we deal with our mood, we understand where we're coming from, and you have a good conversation with your doctor and your healthcare worker to work through that. And of course, we talked about the nose. If the inflammation in the nose is treated, the lungs are better. If you treat the lungs better, the nose is better. Treating them both is important. The concept is it's one airway. So, medications that we have relievers and controllers. The relievers are just that. They relieve the symptom. They don't treat the underlying problem. The blue puffers, they reduce spasm. And of course that helps, but it doesn't. You would be happy taking a cough syrup for your pneumonia rather than your antibiotic, but that's what we do all the time when we just use SABAs and don't use the controllers. So it's usually a blue inhaler. Oh, that jumped. Sorry. And again, it's separate to the controller. Now, I'm saying this a few times because in a recent study that we looked at, we asked asthmatic patients which one was your reliever, which one was your controller, and about half of them got it wrong. So please understand your medication, which one is which and what you're using it for. And I understand that can be confusing. There's lots of medicine, but make sure you got a good idea what medication is doing what. So the relievers will last about 4 hours. The new longer acting will last a bit longer. But again, they don't treat the problem. And if you're using it more than twice a week, it means your asthma is not controlled. And there's actually data that shows that the more beta agonists you use, the worse your outcomes. So really, we want to treat the underlying problem. I want to talk about your relationship with your blue inhaler. Now, I know for many of you, here's your asthma story, because I've seen it many times. You come to the doctor because you can't breathe, you're wheezing, you're uncomfortable. The doctor gives you this blue inhaler, you take it, and within minutes you feel normal, you feel better, and this is fantastic. What a wonderful medication this is. And it's done its job, it's opened up your airways, but it's not treating the underlying inflammation in the lungs. So we say, great, this blue puffer is working, it's the one I want to have, but it doesn't treat the problem. So this SABA risk questionnaire is something I created amongst a group of us with a psychologist named Rob Horn from the UK. And we said, well, let's understand our patient's relationship with the SABA. So I'd like you to just take a moment to take this questionnaire in your mind with me. The first question is, using your blue inhaler is the best way to keep on top of your asthma. 1, you strongly disagree. 5, you strongly agree. Okay? The second is, I don't worry about my asthma if I have my blue one around. 1 is I strongly disagree. 5 is I agree. My blue inhaler is the only one I can really rely on. The benefits of the blue outweigh any risks. I'd rather use my blue rather than the orange. So if you go through, or the red or the purple, if you go through this and you look at this number, and your number is closer to 25 than it is to 5, then you really have a relationship with your blue inhaler that I would say is actually unhealthy. You're looking at the wrong medication to control your asthma. It's not doing the job for you. So what about SABA use? And this is some data that goes up to 2018, some work done by Teresa Toe that tracked at the beta agonist use in Ontario. And what you can see here is that, fortunately, the number of people with less than 4 canisters have gone up over time. But you can see that there's a large number of patients, in terms of something like 20-30%, still use inhalers over 5 times. And there's still a small number that are using more than 12 times, and some even using more than 20. Well, we talked about how many puffs we should be using and consider control. So it's 2 doses a week. 2 doses a week is 2 puffs at a time. That's 4 puffs. Each canister has 200 doses. So at 4 puffs a week at most, that's 1 puffer. 50. That's 50 times 40 is pretty well 1 puffer in a year. So if you need more than 1 inhaler a year, you're not controlled. So think about how many blue puffers you're using, because you'd like to minimize those, and you minimize those by controlling your asthma better. Here's some of that old data. And again, I hate using, when I'm talking to a group of people suffering with the illness, I hate talking about mortality because it's scary. But this is a study from 1992 that was done in Saskatchewan, where they measured the use of SABAs, short-acting beta agonists alone, and the risk of hospitalization or death. And you can see that the higher the number of the short, albuterol is the other name for salbutamol, the higher the number used, the higher risk of hospitalization and, in fact, including death. So if you're relying on just your blue inhaler for your asthma management, you're putting yourself at risk. And this has been shown, this goes back to 1992. More recently, we've looked at something called the Sabina trials across the world. In Canada, very similar. This is a population in Nova Scotia. more than 60% of people use more than 3 SABAs a year. And the higher the number of SABAs, you see less than 1, 1 to 2, 2 to 6, 6 to 12, 12 to 12, the higher the use of SABAs, the more likely they were to have exacerbations. This is one visit in terms of outpatient visits, unexpected. Your asthma is not doing well, you're taking more SABAs, you're at risk of mortality, hospitalization, and death. Please don't count on your SABAs. Make sure your asthma is controlled. So we've done this math already. 200 puffs, 4 puffs a week, should last 1 inhaler. So those of you that are using more than 1 inhaler every year, take a real look in the mirror and say, hey, what are we going to do about that? So controllers are what we need. Controllers are the medication that treats the swelling in the airways, treats that eosinophilic swelling, and controls the problem. We also call them preventers. Okay? They can be by inhalation. There are some tablet controllers as well. Okay? These are things you're generally told to use on a daily basis, and you ramp up that therapy as you require. When you feel better, it means it's working. It doesn't mean it's okay to stop them. It means that they're doing their job. So if you're taking your preventer and you're not grabbing your reliever anymore and you're feeling great and having no symptoms, that is fantastic. I understand the human nature is you feel better, so you stop your medication, but please don't do that. Keep taking your medication. However, have that conversation with your clinician, your physician, your educator, and say, wait a minute, if I'm doing so well on 2 puffs twice a day, could I maybe cut it down to 1 puff twice a day if I continue to do well? Because I think we all want everybody to be on the lowest medication that affects you in the proper way. So we talk about inhaled steroids, we talk about inhaled steroid LABA combination, and the tablets we talk about are leukotriene receptor antagonists. Accolade used to be involved, now we have Singular really only involved in Canada. Here we go. All right, so we talked about that. Maybe a little bit of internet issue. So the steroids come either by themselves or in combination with a long-acting beta agonist. And we said beta agonists by themselves impart some risk, and they do. There was a study called the SMART trial, which is salmeterol monotherapy asthma relief trial. It's a trial in the United States where they gave people free salmeterol, free LABA, and they took the LABA and didn't take their inhaled steroids, and unfortunately 19 young Afro-Americans died. So we know that LABA monotherapy, LABAs without steroids, is bad, potentially bad for you. Just like SABA monotherapy is potentially bad for you. So bronchodilators by themselves don't treat asthma. But when you add an inhaled steroid in the mix, you actually do better than you would with the ICS alone. So ICS LABA combinations actually work very nicely. So here's a lovely poster, and I'm sure on this poster you see the medications you're taking. You can see that we have inhaled steroids, we have inhaled steroid LABA combinations, we have short-acting agents, long-acting agents that can be used as relievers. We have other medications like long-acting muscarinic agents like tiotropium or Spiriva. We have some older steroids you're used to, which is Flovent, Qvar, Pulmicort, Asmanex. We have some newer ones called Arnuity and Arimony. So we have different medications, different devices, and lots of choice. The lots of choice is confusing to you, and it's actually
Okay, we might have to take a quick break and we'll see if Dr. Kaplan can call in. So bear with us for about 2 minutes.
okay. We're back. My apologies. I live in the country, so my internet occasionally does sort of crap out on me, which it just did. So I'm glad that we're back. I'm going to connect up Okay, we're back. Once again, my apologies. Okay, so as we move through this, these medications, there are different devices, and we have to talk about those different devices. So really, the medication we're talking about is steroids, and this is an old picture that I showed many years ago about the concerns that people have about steroids. And I realize these are potentially, it's a scary word to talk about the word steroids. But what I want to say is that really this is the class of medication that is of paramount important for you to be able to use. Now, there is that concern about steroids and Ben Johnson causing big muscles and so on, but that's not the steroid we're using for your lungs. We're using small doses of inhaled steroid to help your lungs. That doesn't mean they're not without side effects. So every medication has the risk of side effects. And we have to recognize that they're there in terms of local side effects, such as having thrush in the mouth and a sore throat. Many of those side effects can be dealt with. Please keep them quiet. Can be dealt with by rinsing your mouth aggressively well and making sure you do that. And some of the steroids are safer than others when it comes to side effects. In addition, if you use a chamber or a spacer, that can reduce the amount of deposition in the upper airway. We've talked a touch about the new reliever in terms of budesonide formoterol, and in mild asthma, using that as required, it works almost as well as using inhaled steroid regularly. But the bottom line is that using steroids regularly is the best treatment for your asthma. So again, decide what you're going to do with your doctor, but this is an option for treatment as well. The concept here for using the Symbicort as a reliever is that by treating the inflammation at the time of the intervention, instead of just giving a SABA, you're actually treating it as it happens, and it prevents this exacerbation from happening. Because all worsenings have a window of opportunity. As things are starting to happen, you have the opportunity to get the steroid involved and prevent the exacerbation. So again, so we talked about this continuum. We talked about the fact that we want to step up our inhaled steroids as we need, add-on therapy as we need, and we have a choice of using a SABA or budesonide formoterol as the reliever. I'm sure you'll have some questions about that at the end. Now, we just had recent Canadian thoracic society asthma update. We talked about that really the management of asthma means that every asthmatic should be treating with inhaled steroids. Right? So that's the bottom line. That's the important step. Fighting with my phone here as well. All right, there we go. And so that's the choice. So we want to use inhaled steroids at the beginning of treatment. What does that mean? You're diagnosed with asthma. Even if you have symptoms or very rarely, you should be treated with inhaled steroid with a SABA PRN. That can be a very low dose inhaled steroid. Some of you say, well, what if I just want to use my SABA once in a while? So they've made these sort of rules that it's okay to use a SABA alone and not use a steroid as well, only if you have very mild asthma, your asthma is perfectly well controlled, you've had no exacerbations, you're not a smoker, and you don't use more than one SABA inhaler per year. And then probably you get away with just using that SABA. But I really want to emphasize that we should be using inhaled steroids regularly. And if you don't want to do that, then maybe using ICS formoterol as your reliever might allow you to do that. We talked about devices, and there's many different devices, be it dry powders, meter dose inhalers, or slower soft mist inhalers with chambers. We don't have enough time to go through all the different devices that are available here. But what I want you to do is I want you to recognize what device you are, and two things. Number one, make sure that your reliever and your controller are in a similar device as possible. Some basics here are that when you use a dry powder, you have to suck it in as hard as you can, whereas an MDI, or meter dose inhaler, you have to breathe it in as slowly as you can. If you use two different devices, there's no way you're going to do both of them correctly. Right? So you want to use the same kind of medication. So that's the first thing. The second thing is that you have to be able to suck in fairly hard for a dry powder, and you still have to make sure that you hold your breath afterwards. Whereas a meter dose inhaler, you breathe in as slowly as you can. Again, you hold your breath in afterwards. So very important to do that. You want to rinse your mouth afterwards especially, and you want to make sure before you take that breath in that you blow everything out. Each one of these different medications, if you go to the Family Physician Airways Group of Canada website, you can see devices. If you go to the Asthma Society website and Lung Association website, you can see devices. And if you just search YouTube and the device of your medication, so just go YouTube and Asthmanex, it'll actually give you a device video for how to do your medication. But what I really want to talk about is that What you need to do with your clinician is have a conversation to understand what the best device is for you. This is an article I wrote with a friend of mine, David Price, about this, where we really talked about matching the inhaler to the right person. Because unfortunately, it's very common for inhaler devices to be used incorrectly. And you may not know you're using it incorrectly unless someone's actually watched you do it. So please make sure you bring your devices with to your doctor's appointment or on your video call, and make sure they watch you use your device, or have your pharmacist watch you use the device, or your educator watch you use the device to make sure you're using it properly. Because disappointingly, this is hard to see, but over the last 60 years, the frequency of patients using the device correctly and incorrectly really hasn't changed. So we're talking about 40 some odd people use it correctly, with the rest not using it correctly. So we really have a problem that hasn't gone away for many, many years. So again, there's some errors that can be made. Some of them are device dependent, some of them are independent. So clearly, in terms of all medicines, if you don't take the top off or open it up properly, it's not going to work. If you're using an empty inhaler, it isn't going to work. If you don't hold your breath for the count of 10 seconds afterwards, it's not going to work as well. If you don't seal your lips around the inhaler, possibly you're going to leak some medication out or not get it properly. Again, breathing in too fast for an MDI or too slow for a dry powder is going to be an issue. And of course, if you don't load it properly, it's not going to work. MDIs need to be shaken up, right? You need to coordinate it a little bit. So what's important is you breathe all the way out. You put it in your mouth or just in front of your mouth. And as you start to press down, you take your slow breath in. Or a dry powder, again, you blow out, you suck in as hard as you can, but you don't blow into the dry powder. If you blow into the dry powder, you're going to disturb the powder and it's going to blow away and you're not going to get your medication. So these are very simple sort of issues there. So again, an MDI, you're familiar with the concept. There's a holder with a canister of a propellant that's in suspension or solution with a mouthpiece, and you activate it by pushing it down and it blows it out. There's a number of different dry powder devices. This is the Discus. Very simple. You just slide the thumb grip on the side there, and that loads powder into it. You suck it in as hard as you can and hold your breath count to 10. Turbuhaler is a different dry powder. You just twist this back and forth. It loads the powder in a little spoon. You suck it in and you get the medication in, but you have to suck in hard enough. Newer devices such as the Ellipta device and the January device, again, very similar devices. Again, you load it. This one, you press the green button on the right. Again, you just open the door there, and that loads the dose for you. Again, dry powders, you suck it in hard. So again, remember, if you have a metered dose inhaler, the energy is supplied by the device, so you have to suck it in slowly. Otherwise, it all blasts in the back of your throat. And you may feel it there and think it's working, but it's not. Right? Whereas a dry powder, you have to do the work, so you have to suck it in hard and make sure you've done that properly. And both sides, of course, you have to hold your breath. So again, that's really important to do that, do it properly. The newer device on the block is called the SlowMist inhaler. This is available only in a few medications, and only some of you have more significant asthma will be on these drugs. And it's a SlowMist. So you load the canister, you twist it back and forth, and it leads out a nice slow spray, much slower than the metered dose inhaler. Spacers are very important. If any of you are using metered dose inhalers, you probably should be using a spacer. The spacer does a couple things. Number one, it makes the timing a little less crucial because the medication goes into the chamber. Number two, it dilutes some of the bigger particles so they fall into the chamber. So just the small particles that reach the bottom of your lung are reaching your lung, so you get less thrush and things like that. Right? So it makes it easier for the medication to reach the lungs. There's less irritation to your throat. And all children, if you have a child with asthma who's on a metered dose inhaler, inhaled steroid, they should be using a spacer, period. No exceptions to that at all. So here's an example of true inhaler technique. And yes, that is my cat, not my child. My cat had asthma. It sounds pretty amazing. My cat had asthma. But we used to give her medication in a chamber called an AeroCat. And she used to come running for it. She used to have a treat after, which was really good about it. I'm hoping that you've got some kind of an action plan. And if you don't, then that's something you should work on with your educator or your clinician. The concept here is a green zone means things are going well. You take your regular medicine. Your yellow zone means you're having some symptoms. You're using your blue puffer more often. You have to step up your therapy. We often talk about quadrupling your dose of inhaled steroid. And the red or the orange zone means go to the hospital and use a lot of puffer till you get there because you're very, very sick. The action here is the yellow zone. So you have to know, wait a minute, things are getting a little worse. And the big thing here is to not be in denial. So I'm recognizing it's a bad pollen day. I have grabbed my blue puffer. This doesn't look like it's going to be a good day. We'll immediately quadruple your dose of inhaled steroid because that's going to treat the symptoms when it's happening and prevent you from going on to having exacerbation. So the green zone means everything's okay. You're sleeping well. You're not eating your blue puffer. That should say 2 times a week, not 4. Okay, you take your regular medications, you keep being active, it's good for you. The yellow zone means, hey, you're using it more than twice a week, you're waking up, you're up at night, you're having symptoms with exercise, it wasn't happening before, quadruple your exercise, and it's time to perhaps call your doctor because you want to make sure that you're on top of this, because this is what we want to do. We want to act here in the zone to prevent you going from the red zone, prevent you having to run to the hospital, prevent you needing prednisone at your doctor. So if you're really sick, then get some help. And if you're actually blue and pale and sweaty and you can't breathe, call an ambulance and take lots of puffers. I'm going to reiterate the key in using an action plan is to activate it early. This is a study done by a colleague of mine, Martin Partridge in the UK, and he looked at patients' behaviors when they were starting to get an attack. And you can see on the left that they very readily increased their SABA, their short-acting beta agonist. But they were told to increase their ICS, but they didn't. You can see what happened is they waited a few days, and then instead of quadrupling, they just took an extra puff. I understand it's human nature. Let's see if I really need it or not, because I'm not sure I actually need it, so I'm going to wait. And then when I wait, I don't really want to take 4 extra, I'm going to take 1 extra. But you see, if you want your action plan to work, then you have to use it the way it's been designed. So again, you can go to the asthma.ca where there's a number of booklets talking about diagnosis, triggers, medications, how to deal with this in children, some wonderful resources. I was involved in creating some of them, that's why I say they're wonderful. But please take advantage of the people there that are wanting to help you. Kristen wanted me to touch on severe asthma as well, and I think this is something that we do need to talk about. So severe asthma means, this is from an old definition, it's patients who, despite doing everything right, you're taking your ICS LABA in good dose, you've added on another controller, you've dealt with your triggers at home, you've dealt with your comorbidities, and you're still needing prednisone a couple times a year, or you're still not controlled. Well, that means you've got severe asthma. That means you need a step up of therapy, an assessment by someone who can evaluate this. Most family doctors don't have the tools to do this. And if you're in that group, then and if you're using prednisone a couple times a year, you need to have a conversation with your doctor about what you're going to do to try to prevent it. The first thing, of course, is to make sure you don't need the prednisone by taking your medicine. But if you've done all that, you may end up into one of these phenotypes. And this is very complicated. Let me just go through it quickly in terms of types of people that can have severe asthma. The majority is this Th2, and that's eosinophilic inflammation, allergies, and things like that. And we have really excellent biologics to work on that kind of inflammation. Some of it's non-Th2. We've talked a little bit about obesity, and there's new things coming. We talked about smoking associated. There's a small group of asthmatics that have just very significant smooth muscle hypertrophy and twitchy airways that require something different called we actually burn the lungs a little bit. So these are very fancy treatments in here, but these biologics we use in this group here with Th2 disease are actually fairly easy to use. They're an injection either every 2 weeks or up to every 2 months, depending on the medication, and they work beautifully to make a difference for that. So again, here's my touch on inflammation. On the left, we talked about this. You can see on the right side of the left picture, you can see the asthma, the purple and blue, purple and pink eosinophils in the airway causing all the swelling. But underneath all that is this really complicated cytokine pathway that includes interleukin 4, 13, and 5, and IgE, which is related from beta cells. That all isn't important. What's important here is if you have severe disease, and you've had recurrent exacerbations, you're not controlled despite medications, this is a time when your family doctor may need some help from someone who can decide which inflammatory pathway you're in and what kind of biologic might be of value to you. The difficulty, of course, these medications are not cheap. They cost as much as $25,000 a year, so coverage of them can be quite a bit of a barrier. But again, we have medications that treat IL-5, that treat IgE with the beta cells over here, that treat IL-4, 13, and these medications can treat asthma. They can also treat eczema. They can also treat nasal polyps. So they do a wonderful job at treating these different diseases. So we do have a method of doing that. And we actually have a Canadian guideline that needs to be updated. It was last done in 2017. GINA, the Global Initiative for Asthma, has one a little more updated. But you can see here, the picture here is make your diagnosis. So again, spirometry is going to have to be done to assess. Go back to the basics about control, medication adherence, medication technique, dealing with comorbidities. And then once you've done that and you've treated and stepped up to ICS LABA plus other therapies, assess the phenotype. Now, very quickly, these are tests that you're not going to be involved with, but just what your doctor will do, they'll do a blood test called an IgE level and do allergy skin testing if you haven't had that done. They'll do your blood count to measure your blood eosinophil count. They may do fancy tests like FeNO, which is a breath into a machine measuring fractionated cell nitric oxide, or they may send you to a couple of places in the country that does sputum eosinophils, where you cough up some sputum onto a slide and they check for eosinophils. All of that helps us decide whether we use omalizumab, which is IgE, IL-5 therapy, and there's 3 of them, or IL-4/13 therapy. So there's lots of choices. But again, this is good. This is the purview of people who have that significant interest and emphasis in that condition. But what I want you to know is that it's available for you. So the severe asthma chart is a global initiative that's created. And I really like this charter. And I think that you guys should, as patients and sufferers with the disease, you should actually think about this. That if you've got anything other than mild asthma and you need help, that you deserve a referral. So ask for it. I think asthma is mostly a primary care disease, and I'm a family doctor, although I have an expertise. So I think family doctors can look after the majority of patients with asthma. But if you're not doing well, you need to break through these issues with your doctor, understand why. And it's not unreasonable if you're someone with more severe disease to get a referral. You need a formal diagnosis. We need to have spirometry done. You need to phenotype if you have severe asthma so you get the right treatment. You should be able to get the quality care you need, but of course, funding is going to be an issue for that. Again, I hope that none of you are reliant on oral steroids. I am taking prednisone on an everyday basis. That has a whole list of really bad side effects that we really want to avoid, and these biologics can help you come off your oral steroids. And I have the right to have quality care no matter where I live. And of course, Canada is a very big country that's very far from place to place. So how do you prepare for your appointment with your doctor? Well, the first question is, are you controlled? So you ask yourself those questions. Am I controlled? Is my exercise limited? Am I grabbing my short-acting beta agonist reliever more than twice a week? Am I sleeping through the night? Have I missed any work or school? If you're not controlled, then you want to go through those questions of why. We've talked about them. Are you taking your medication regularly? Are you taking it properly? Do you have a trigger that you can't get rid of? Do you have a comorbidity that needs to be treated? Or maybe you've got severe asthma. If you haven't had a test of lung function, then you need to have that done. A little difficult to do this right now because of COVID, and spirometry is an aerosol generating procedure. So the areas where you can get spirometry testing then is more limited now. So that may be a bit of a barrier, but again, it's something to be arranged for down the road. Have you been to the hospital? Have you had a course of prednisone? Your doctor may not know. Actually, our healthcare system is very fragmented. So you've been to the emergency room, I may not get a note about you to know that you've been there. You've been to a walk-in clinic, they never send a note to the family doctor to say they've been there. So we don't know you've had an exacerbation and been there and got a course of prednisone unless you tell us. So please make sure to do that. And of course, treat those comorbidities. If you have got a stuffy nose and no one's paid attention to that, say I've got a stuffy nose, you have to treat my rhinitis to treat my asthma. If I'm having heartburn, we talked about the fact that heartburn can exacerbate asthma, and you have to make sure that's there. So here's a nice little app that was created by one of the companies that makes Alvesco, one of the inhaled steroids, called learnaboutasthma.ca. And that's one website you can go to learn about asthma. It's a very nice little app that tracks your symptoms, which is nice. There's many others like that as well, but here's one, learnaboutasthma.ca. And of course, you can go to the Asthma Canada website, which has all kinds of information. I'll talk about that in a moment. So these are some initially frequent asked questions I thought I'd just go through quickly, and then I'm going to get to your questions. What's the difference between corticosteroids and anabolic steroids? Anabolic steroids are the ones that give you big muscles, and Ben Johnson. Corticosteroids are inhaled in microgram doses to control the swelling in your lungs, and they are very safe. They are not addictive. What's actually addictive is use of SABA, because if you don't treat the inflammation, you need more and more SABA until, of course, you have a problem. Prednisone is steroids in the milligram dose, 1,000 times stronger. So if you're afraid of prednisone, that's a healthy thing to be afraid of, to be concerned about. We want to avoid the use of prednisone. So we can avoid the use of milligrams of prednisone by using micrograms of inhaled steroid. So by using small amounts of inhaled steroid, we can prevent the use of oral steroid, which has a lot more side effects. If you have persistent asthma, then you have inflammation all the time. That time may be variable. There may be times it's a little better, a little worse, but you need to take your medication all the time, perhaps the lowest dose to keep you controlled, but you've got a chronic illness that requires chronic treatment. You don't like to hear that statement. You've got a chronic illness, but if you respect the fact this is a chronic illness and stay on top of it, you should be able to live a completely normal life. If you're pregnant, should you take your medications? Well, yes. The rule of pregnancy is 1/3 get better, 1/3 stay the same, and 1/3 get worse. So first step is make sure your asthma is in control. You're not only treating you, you're treating your baby. The medications you treat with asthma don't harm the baby. There's no concern about that, other than having exacerbation needing prednisone. But what's more important is that your oxygenation level and the baby's oxygen level is much more tenuous. So a little bit of drop of oxygen for you is a lot of drop for the baby. So the message is keep your asthma controlled, because the last thing you want to do is have an exacerbation. And I feel better, can I stop my medications? No. If you've got asthma, you have a chronic illness, and you have to stay on your medications, you may be allowed to use the lowest dose possible. I want to touch on the environment. There's certainly some evidence that meter dose inhalers have propellant that can damage the environment. So my preference is to move to dry powders if you're able to use a dry powder properly. And the number is something like, if you switch from an MDI to a dry powder, you'll save the equivalent of driving 54 kilometers per patient per month per puff. So I think that's something we have to think about for the future. Other questions. Can alternative therapies help my asthma? And I don't want to diss the alternative therapy people, but my experience has been no. You want to avoid triggers and treat your asthma with proper anti-inflammatories. Are there medicines you should avoid? And the answer is potentially yes. You've got to be very, very careful with beta blockers, which are blood pressure medications, heart medications, and drops in the eye. And you have to work that out. If you need the medication, you have to take the risk-benefit ratio. You got to be careful with anti-inflammatory drugs, because in some people that triggers the asthma. Steroids cause weak bones and growth suppression. Is that true? And yes, it does. Oral corticosteroids will do that. You want to avoid the use of oral steroids by controlling your asthma. Inhaled steroids in high doses for a long time will have some effects as well, so we want to use the minimal dose that keeps you controlled. How do I know that inhaled steroids won't cause health problems in the long term? Well, the risk of having bad outcomes from your asthma, the risk of having side effects from oral steroids greatly outweighs the risks of using inhaled steroids on a regular basis. So a little bit of inhaled steroids now will prevent the use of oral steroids and complications later. Big picture is treat your asthma. Are there any controlling medications that do not have steroids in them? And the answer is yes. We have a couple of them. One is the leukotriene receptor. We talked about that singular. The problem is that it doesn't work for all people, and it's a very weak medication. We have other medications, other inhalers that are non-steroid, like Intol, which is an old medication that doesn't work terribly well compared to steroids. We don't tend to use it a lot. And of course, biologics don't have steroids in them either. So here's the website you should know about, asthma.ca. There's a helpline. So you can call and speak to someone if you have things like newly diagnosed asthma, how to manage symptoms, how to deal with your triggers, and any question you can come up with, you can actually contact their helpline, and you can email them to talk about that. So please, you don't have to do this on your own. You can get help, and getting help from the Asthma Society and asthma.ca can do that. So again, here's where you can sort of get some more questions. If you want to just send an email at info@asthma.ca, you'll get that answered. Plus, if you want to speak to a certified respiratory educator, I want to talk about what a certified respiratory educator is. These are people, whether they're pharmacists, nurses, RTs, who've gone through an educational program and taken a very rigorous exam to make sure that they are evidence-based people that know the guidelines and work with the guidelines. And they're very educated, very specifically trained people that can help you with your asthma. Take advantage of them. They're there ready to talk to you. They want to talk to you. They want to help you. Reach out to them and ask questions. If you have questions from your interaction with the educator, it's perfectly okay to take those questions back to your physician. Say, I was speaking to the educator and they suggested that we think about this. What do you think about that, doctor? And most of the time, your doctors are going to be very receptive to those things. So I'd like to thank you for joining. I know whether Kristen wants to have this, but I'm just going to make a mention to the fact that Asthma Society is a charity, and of course, it has to get donations in order to survive. So if you want to go to asthma.ca/donate, you can talk about how to give them some money. But I'll let Kristen talk more about that as she introduces the questions that she's got, and I want to thank you for your attention.
Thank you so much, Dr. Kaplan, and you said that much better than I could, so appreciate it. We have had so many great questions come in through the chat box, and some of them your presentation has answered, actually, so that is wonderful. But I think I'd like to start with a question we received from Beth, who asked, why does asthma return in old age after 30 years of being virtually free of symptoms?
I think I heard you say, why does asthma come back after being symptom-free for many years? Is that right?
Yeah, that's correct.
Okay,
a question
thank
from
you.
Beth.
So I'm dealing with deal phones and stuff here to try to hear you, so I'm sorry.
The joys of virtual.
The answer is, let me try something else. Technology is this issue. Say something now.
Our question from Beth.
No, it's not working through there. Okay. So, I'll come back to that. So the answer is in my answer about the fact that asthma is a chronic illness. So while you may grow out of it, and that's something people talk about, that's your body's immune system responding to it and improving. But with a trigger, with the proper circumstances, that inflammation can build up again. So if you have asthma as a child and you had allergies and asthma and the whole thing, you probably have the risk of developing asthma for your whole life. And while some people do grow out of it, the majority don't, and it's not uncommon for it to come back at a later age. You haven't done anything wrong, unless you started smoking or got a pet you're allergic to, or so on and so forth. So think about your triggers, think about what you can avoid and get rid of those triggers to decrease your symptoms. But it just means you've got the chronic disease of asthma and you have to take care of it.
Excellent. This is along sort of the same line. So Sylvie says, I've had asthma for 10 years now. This year is the first time I've had more difficulty controlling my asthma because of seasonal allergies, which I've never suffered from before. Does this mean that my control medication is not working as well anymore, or is it possible I'm just more sensitive this year? And what do you recommend additionally for the symptoms?
So it's a little hard to answer specific questions, but let me give you an idea. We talked about this is all related to inflammation. It's all related to that inflammatory reaction in your lungs. And this year, allergy season has been pretty wet, so there's sort of a lot of grass molds and stuff out there. Grasses and trees are happening, so I can certainly see how allergies might be flaring you up. We all respond differently to allergies and differently in different years, but what happens is your body has an allergen come in, and it meets these antibodies in the body called IgE, and those IgEs then go together with the allergen and go on to something called mast cells and release a bunch of mediators that cause symptoms. So if we can prevent the exposure, that's going to make a difference. But if the exposure is happening and your system is turned on, then we have to dampen the treatment and dampen the inflammation by treating it. So for you, it's frustrating because your symptoms are a little bit worse, but what it means is you've got to step up your therapy. So if your allergies are bad, your nose is probably bad, so you have to be treating your nose as well as your lung. So it's not that your medications aren't working, it's just the inflammation has continued to increase. And because it's worse right now, you may need to step up your therapy a little bit to get control of the symptoms. So remember that you may need a little more symptom treatment for your lungs. You may also need some treatments for your nose. As a rule, for your nose, nasal corticosteroids may help that. Antihistamines may help your nose, but don't help the asthma. And one other little hint for all of you, if you've got nasal symptoms, that as you breathe in your inhaler and you hold your breath for the count of 10, the inhaled steroid, when you blow it out through your nose. And then you're going to get some steroid being blown out your nose, and it will help your nasal symptoms as well. Montelukast may also be something you consider adding on this time of year because it helps the allergies as well. That's another good choice for you. But again, just stepping up your therapy somehow may be the right answer. And again, when the allergy season's over, as we get into the fall and the winter, perhaps you can cut back therapy again.
Perfect. And another question we have from John, and I will be mindful of time because I know we're a touch over 5, but John asks, why does coughing accompany asthma? What does it accomplish in the body?
So if you remember the picture I had of the airway and that big mucus plug that was in the middle there, so if you think about the airways being swollen and being in a little bit of spasm, so spasm can present as cough sometimes, but that mucus plug has to be cleared out as well. That's why there's often a bit of cough. So the cough is your body's attempt to clear secretions and clean things out for you. So it's a normal thing. In addition, if you've got nasal symptoms, you've got postnasal drip, it's going to drip down and cause symptoms. So the cough is your body's appropriate attempt to clear secretions, be them upper or lower airway secretions. And also, it may be a symptom of the spasm and inflammation going on in your lung. Not all cough, though, is asthma. So we have to make sure that if you're being treated for your asthma and you're still coughing, you may want to look into other things that can cause the cough. That's something to talk to your doctor about.
Perfect. Okay. And I'll sneak in one more. Kim asks, I know there are several different subtypes of asthma. How soon do you think we'll see more targeted therapies available?
Well, there's lots of targeted therapies available right now to answer your question, and it's a fantastic question. And the issues here are when to start these targeted biologic therapies. Right now, the studies have been done on them in people with much more severe disease, moderate or severe disease. But frankly, they'll work in all asthmatics if they're the right target for that person. So if someone has an elevated blood eosinophil count, an IL-5 will work fine whether you have moderate disease, severe disease, or even mild disease. The issue, of course, is going to be cost and availability of these medications because at $25,000 a year, not every mild asthmatic can get a biologic therapy. But I think over the coming years, as the medication costs come down, biosimilars are created, it may be that we actually can start medications a bit earlier. In addition, that picture I showed you of the pathways of asthma, some of the pathways I didn't talk about, and there's some newer ones coming called TSLP, which is higher up in the immune system, which actually may be something we can act on earlier on in the illness to prevent the airway disease from occurring. So this is all being investigated right now, talking about earlier intervention with biologics and newer biologics that we're not even using yet routinely. They're still just in investigation. So I think it's a really good question, a very insightful question, because right now we're a little bit treating this broadly. We're giving everybody the same kind of treatment, an inhaled steroid, a bronchodilator, when in fact we can target our therapy based on the immune mechanism going on in the lung, but we're not quite there yet. But it's being worked on right now, and we have really wonderful medications and a lot of amazing people working on this. So I think that if you think about what's happened in the last 10 years compared to 10 years ago, where 10 years ago we only had one biologic, which was anti-IgE, and now we have 5 or 6 different biologics, it's really exciting. And I think those numbers are just going to continue to proliferate and give us more choices over time. So please be hopeful to that future. The answer isn't there now, but it is coming, and I think we're going to have more options coming in the very near future.
Perfect. And I would be remiss if I didn't mention one of our most common questions, and that is it safe for people with asthma to get the COVID-19 vaccine?
Well, thank you so much for asking that question, because that's really, really pertinent right now. And I just told you about me working on a vaccine hesitancy talk. So all of you that are vaccine hesitant, let me give you a very simple answer. Please, please get your vaccine. The only way we're going to eradicate this illness is by getting everybody vaccinated and preventing these variants of concern from mutating. So diseases only mutate when they're around. If they're not around, they don't mutate because they're dead. So we have to look after ourselves and everybody around us by getting vaccinated. As an asthmatic, if you're a mild asthmatic, your risk of developing COVID is no higher than anyone else's. Your risk of severe COVID is actually no higher than anyone else's. But if you have a significant degree of asthma, you have more severe asthma, you have some airway obstruction that's fixed, then your risk of severe COVID is actually higher. So the best thing you can do about COVID and asthma is 1, keep your asthma in control, and 2, vaccinate. The only caution I would have about vaccines is if you happen to have a history of anaphylaxis, then the Pfizer vaccine has a little bit of a higher risk of anaphylaxis, and I probably would choose a different vaccine rather than Pfizer. Otherwise, I think all the other vaccines are safe. And yes, I know you're worried about blood clots and AstraZeneca, but quite frankly, the risk of dying from COVID is many, many times higher than the risk of a blood clot from the Astra vaccine or the Johnson & Johnson vaccine. So my message is please get whatever vaccine you can. If you have a choice, then fine, you can make choices based on your thoughts. But if we look at the UK right now, the UK only had AstraZeneca vaccine because it's made in the UK. That's the only one they've had. And now they have had no new cases of death today. They're opening up everything in the UK because their population has been so extremely vaccinated. That's what we need here in Canada. So please, please get your vaccine, not just because you have asthma, but because you're a mother, father, child, relative, friend, coworker, to make sure that we're all protected and we can get our life back to normal. That may have been an overabundant answer, but that's how I feel about it.
No, thank you so much, Dr. Kaplan. One of the other questions that came out was, will this presentation be available as a copy? So yes, absolutely. It will be available on asthma.ca, as well as we have an entire resource section where you can find the booklets that Dr. Kaplan mentioned earlier, and asthma action plans as well. So I just wanted to thank you so much, Dr. Kaplan, for being with us today. We've been receiving lots of feedback in the chat that this is really helpful. And thank you to our audience for bearing with us today and asking your important questions. Again, thank you so much. Take care, everyone. Stay safe.
I'm just looking at a couple of questions in the chat. So before we hang out of there, just for clarification, there was a question about tiotropium being inhaled more slowly than Symbicort. So a dry powder, you inhale fast. Tiotropium is a soft mist, so it can be inhaled slowly. And you hold your breath after every single inhaler. So if I didn't make that clear, please make sure you hold your breath for the count of 10 after everything you take into your lungs to give it a chance to work. I'll stop talking now. I'll thank you all for attending and apologize for my internet issues, but that's life in the country. Have a good day, everyone.
Thank you so much, everyone. Thanks, Dr. Kaplan. Take care.
Take care now. Bye-bye.